Omar, en lo que se anima alguien del público, en Puerto Vallarta, en una hemorragia, ¿qué haces? Lo ideal es lo que hiciste, pero en la vida real, ¿qué pasa?
Bueno, diferentes médicos endoscopistas contamos con accesorios y habitualmente, si la hemorragia está activa, lo primero es obviamente identificar el sitio de hemorragia, tratar de determinar la etiología, y si se puede localizar muy bien, lo primero es una terapia de inyección para tratar de detenerla o disminuir, y después agregar algún otro tipo de tratamiento. Habitualmente utilizamos los endoscopistas que estamos allá, terapia mecánica con clips es lo que más utilizamos.
Gracias, Omar Edel. Dr. Langton, which is your best advice for endoscopists young to perform a colonoscopy? Best advice to do for the young endoscopists?
John.
The best advice? Yeah, I think the best advice is the most important thing is to explain to your patient the importance of why we're doing the exam and the importance of doing a good prep and how to do it. I didn't spend a lot of time on that because sometimes patients don't understand why they're doing the prep. You know, I think that the other thing is to remember that we have a good choice of different preps, you know, from high, you know, so we have to really understand the patient, because if they're constipated, you probably want to use a 4-liter prep. If they're not, then you try to use the lowest volume possible. But I think that the prep and talking to the patient before the procedure is one of the most important things that we don't do often enough, at least in the United States.
Mauro.
I think that's very important. The other thing I also tell our fellows as they are learning colonoscopy is to sedate the patient adequately before they actually start. I think Mayo Clinic, Arizona is one of the few places where we are still using moderate sedation. I don't know what the practice is in Mexico. Most of the centers in the United States are actually using propofol, and I think that unfortunately does not allow the patient to provide us feedback when we are learning how to scope. I don't know what the practice is in Mexico, but for moderate sedation to succeed, where you're actually giving sedation as you're scoping the patient, you have to make sure that the patient is adequately sedated and not constantly catching up. So that's another piece of advice I give to the younger endoscopists as we are learning to, as we are teaching endoscopy.
I think in Mexico we don't have the possibility to do moderate sedation in all the colonoscopies. But in private practice, I think we use the moderate sedation. But in public health, I don't have that possibility.
Gracias. Felicitar a los profesores de todas sus pláticas. Para la doctora Hernández, ¿cuál es la estrategia para difundir los programas de escrutinio en México? Muchos de los hospitales de referencia están saturados de pacientes con lesiones avanzadas de colon. Entonces, ¿cuál es el estándar de atención de las autoridades, de las instituciones médicas, de las organizaciones médicas para difundir los programas de escrutinio en nuestro país, para tratar de que esa tendencia de las lesiones avanzadas vaya disminuyendo?
Sí, gracias, Eduardo. Bueno, creo que es el problema que hemos estado trabajando desde hace mucho tiempo. La verdad, no tenemos mucha respuesta. En este año hicimos hemos trabajado en un programa, en una propuesta para hacer o enfatizar el problema, para demostrar el problema y para presentarlo ante las autoridades de salud. Espero que ahora el doctor Karsenovich nos haga caso con este trabajo de posición que hicimos hace algunas semanas, en el que planteamos la necesidad de establecer un programa, tal vez no organizado, que sería lo ideal, no organizado que todo el mundo lo haga, sino por lo menos oportunista, pero con métricas especiales para evitar lo que bien comentas. Tenemos los que vemos cáncer, la gran mayoría de nuestros pacientes están en etapa clínica 3 y 4, que van a tratamientos puramente paliativos con un costo muy alto, y que si no hacemos nada, y esto lo ha demostrado la Organización Mundial de la Salud, si no hacemos nada en los siguientes años se van a duplicar los casos y vamos a tener un costo mucho más alto para esto. Entonces creo que hay un grupo que hemos estado trabajando y empujando con la Secretaría de Salud y con las organizaciones no gubernamentales, fundaciones, con la finalidad de hacer un trabajo de posición, presentar un proyecto de protocolo y invitar a toda la gente para que podamos trabajar en esto. Pero en este momento no hay un programa. Tenemos en el instituto un programa piloto, y que lo que queremos es sugerir y normar algunas conductas para poder realizar un buen programa de tamizaje en México.
Si dices tu nombre y haces tu pregunta, por favor.
Sí, buenas tardes. Daniel Urbina, de Ciudad Juárez. ¿Qué recomendaciones darían para preparación de colonoscopía a pacientes con cirugía bariátrica que tienen limitación para tragar de la... He tenido problemas como encontrar cuál sería la recomendación más adecuada en estos pacientes?
He wants me to answer. For colonoscopy preparation, I think Dr. Layton might be a better person. So I think he's asking what would be the best preparation or the optimal preparation for someone with bariatric surgery and is being prepped for a colonoscopy. Any recommendations?
If they've had bariatric surgery, I tried to go with a low volume prep, 2 liters or less, either what we have is movie prep or soup prep. But unless they have a history of constipation, we would go with a low volume prep.
¿Y en México qué recomendarían?
Yo creo que lo ideal serían estas dosis divididas y un de bajo volumen para hacer la preparación. Al final de cuentas, en alto volumen son 4 litros y la capacidad es menor, el tránsito es mayor y tal vez la respuesta sea más rápida. Creo que podríamos llegar a proponer dosis dividida o preparación con bajo volumen.
Miguel Ángel.
Muchas gracias por sus conferencias a todos. Thank you for your lectures. I have a question, very important question. There is an epidemic using GLP-1 agonist. So what is your advice for patients who are going to submit it to an endoscopy or colonoscopy in terms of stop using GLP-1s in order to avoid bronchoaspiration or complications during the sedation?
So I have to preface everything I say by the fact that I think there is no uniform recommendations. Some of which is dependent on what our anesthesiologists tell us. For moderate sedation, I have to say where I think we have more control, the AGA has actually said there is no evidence to suggest that there is an increased risk of aspiration if you continue using the GLP-1 agonist till the day before the endoscopy. So for moderate sedation, we are actually not recommending in our anesthesia unit to discontinue the medication unless the patient has a history of proven gastroparesis. Our anesthesiologists, I believe, are actually on a different page. And they are recommending that these medications be stopped at least a week before the procedure. So there continues to be, in my opinion, a dichotomy between the way gastroenterologists are reading the evidence and anesthesiologists are reading the evidence. So I don't think that is an ideal situation, but I think that's where we stand at the moment. Jonathan, you have something else to say?
I basically agree because the anesthesia guidelines, they may be correct, but their guidelines are based on no data. Nick Shaheen's group did do a retrospective study and found no difference in risk with patients on or off those medications. The only drug that was a risk was narcotics. So, yeah, I don't think there's evidence at this point, you know, that we need to stop any of the medications.
Estamos aprendiendo que muchos pacientes tienen retención gástrica. The retention gastric is a very problem in that kind of patients. No hay una norma de qué hacer, entonces yo creo que suspender por lo menos una semana antes sería una buena opción, pero como que no hay una norma de qué hacer con estos pacientes hasta el momento, ¿no? Primero las damas, por favor.
Good afternoon. For Dr. Prasad, I would like to ask if, in your experience, have you ever seen any real difference for which is better between knives, the cap, or band ligation for the Barrett esophagus lesions?
Sorry, could you repeat your question? Sorry,
Yeah.
I'm not able to hear very well here.
In your experience, have you ever seen if there's like a better method for the Barrett esophagus lesions resection between the knives, the cap, and band ligation?
Which is the best for
I see what you mean. Okay. So are you talking about a preference in terms of cap EMR versus ESD? Yes. The distinction between the two is, or the indication for the two is based on a few things. So if you have a smaller lesion, say something that is 15 millimeters or less, then I think a cap or a band EMR is enough. If you have something that is 20 millimeters or more and you want end block resection, then ESD would be the better way to go. So that's number one, size. Second, if you're concerned about submucosal invasion, so something like a type 2C lesion or a type 3 lesion, probably type 3 you're not going to resect anyway, but let's say you're thinking about a more submucosally invasive disease, their ESD might be better than EMR. Third, if you have a suspicion of fibrosis, so someone who's had prior radiation, someone who's had prior ablation, someone who's had a prior EMR and your margins are not clean, their ESD is probably better because you can dissect deeper in the submucosal plane closer to the muscularis propria. So those would be three areas where I would think ESD would be better than EMR.
Hola, felicidades por las pláticas. Isaac de Ciudad de México, for Dr. Ayer and Dr. Layton. Thank you for your lectures. Two questions. The first one, are you using for everyone AI to detect lesions in the esophagus and colon? And the other one, are you using some like prototype to use AI but for surveillance? So like a software that can put in all kinds of inputs so we can miss less interval cancer or miss less dysplasia that goes to adenocarcinoma? Are you doing something like that?
Regarding the first question, you know, at Mayo, we're not using AI now. You know, from this is my personal opinion, at this point, using artificial intelligence mostly picks up small lesions that, you know, aren't going to affect outcomes significantly. Now, if you have if you have someone who has a low ADR, then I think that those are the people that might benefit from using AI. But I think for those with a high detection rate, I don't think AI necessarily adds more. I think that where it could be useful eventually is, as you suggest in your second question, is you know, for picking up more subtle lesions, particularly sessile serrated lesions or flat or invisible dysplasia. But the artificial intelligence doesn't do that yet. And when it does, that will be, I think, a big addition when we can pick up very subtle lesions with AI. But I don't think we're there yet. Do you agree?
Yeah, I think, so another point I'd like to make is for Barrett's, there is nothing commercially available just yet. I think there are techniques that are being studied. I think there's something that is being done in the Netherlands. There are a few other companies, but for Barrett's, there is nothing that is commercially available just yet. The second point, I think, is that from the evidence that we have in the colon, AI seems to help in randomized controlled trials, but most of the studies that have been done in the community, the yield has not really gone up that much yet. And I think Dr. Layton makes a great point that most of the increase in yield in randomized studies is on the basis of smaller polyps, not necessarily the larger polyps, not for providers who have high ADRs. So the benefit seems to be more for providers who have low ADRs. And then lastly, I agree with what Dr. Layton said. Most of the evidence is in terms of some of the adenomas. We yet don't have good AI programs for right-sided lesions or serrated lesions. Hopefully, programs like GI Genius will add those modules, and then it'll become more helpful. And lastly, I don't think AI as a modality is being reimbursed yet. So you have to invest in the program from the physician side, but I don't think there are codes yet from Medicare or from the private payers where if you use AI, you're actually going to get paid. So that's the missing link.
Dr. Langton, when do you send to a surgery when a patient has perforation in a colonoscopy? Do you treat endoscopically always the case, or when do you send to surgery?
Well, you know, fortunately, I don't, because I don't do advanced polyps often, I have not had significant perforations. If I do have a perforation, we have clipped them closed, and they've done very well. I also clip if you see the target sign, because that target sign tells you that you caught, you know, muscularis. So if you have the target sign, you want to clip. If you do a cold snare and you get that little fibrous plug, you don't have to worry about that. That's normal. And although it's sort of scary looking when you see it come up, you don't have to worry about that. But I think that I know my therapeutic endoscopists mostly repair, you know, they do create perforations, and they almost always treat it themselves with clipping, either over the scope or through the scope. And I think it's rare that they send someone to surgery. Prasad, do you know otherwise?
I think I agree with what Dr. Layton is saying. We make an effort to close the defect endoscopically. We typically will put the patient on antibiotics, keep them in the hospital overnight, and maybe have the surgical service actually consult. But typically, I would say the odds of them taking the patient to surgery are very low in my mind, as long as the patient is improving or remains stable. If the patient deteriorates, then I think the surgeons will probably take the patient to the OR.
And I would say, you know, that's different for a delayed perforation. A delayed perforation,
Yes.
meaning a patient comes in with fever,
Yeah.
peritonitis, obviously, then that is an indication for surgery.
Sí, creo que la gran mayoría son cierran, o sea, se pueden cerrar en el momento, ¿no? Cuando es una perforación advertida, y que incluso dentro del procedimiento de resección o disección endoscópica es parte del procedimiento, puede ser. Y aquí lo más importante, hay clips que son de afrontamiento, ¿no? Porque antes eran clips hemostáticos los que utilizábamos, ahora son clips de afrontamiento que permiten hacer un cierre mucho más seguro. El cuidado 24 horas en las siguientes horas es muy importante para decidir si fue suficiente o fue segura tu aplicación, y si no, estos pues sí ya tendrían que ir. Y la diferencia de lo tardío, en later ya es el problema, ahí ya es quirúrgico, ¿no? Ya hay complicación.
Pues muchas gracias, gracias a los organizadores, gracias doctor Layton, doctora Guerrero, Prasad, doctor Trujillo, muchas gracias. Los esperamos mañana para el segundo día de este curso.